Hello, everyone. My name is Subarna, and I'm so happy to welcome you all to the fourth annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department in partnership with the Washtenaw County Medical Society. This virtual series is aimed towards healthcare providers with the goal of raising awareness and opening discussions surrounding cannabis use for medical practices. Our speakers come from a wide range of backgrounds and are experts in their respective fields related to medical cannabis. Funding for the series comes from the Michigan Department of Licensing and Regulatory Affairs, Cannabis Regulatory Agency. I'm so pleased to introduce today's speaker, Dr. Laura Borgelt. Dr. Borgelt is an Associate Vice Chancellor of Strategic Initiatives at the University of Colorado Anschutz Medical Campus and professor in the departments of Clinical, Pharmacy, and Family Medicine. Dr. Borgelt's teaching, practice, and research focuses on patient safety and women's health. Her initial interest in educating providers and patients about medical cannabis started about 10 years ago when she was asked clinical questions about its use in pregnant and lactating women. Since that time, she has investigated the potential effectiveness and risks of cannabis in a comprehensive manner and has provided evidence-based presentations to medical, nursing, pharmacy, and patient organizations at the state and national level. She has served on 8 different working groups regarding rulemaking in the state of Colorado, involving consumer safety and social issues. Through her training and experience, Dr. Borgelt has extensive knowledge of cannabis with regards to its pharmacology, pharmacokinetics, pharmacodynamics, therapeutic effectiveness, and potential risks. Her evidence-based, balanced approach to identifying potential benefits and risks of cannabis is important to determine its appropriate use. Thank you so much for joining us today, Dr. Borgelt. I'll let you take it away.
Thank you so much, Sabrina. Such a kind introduction. I'm going to go ahead and share my screen here for you all and hopefully be able to get this into presenter mode. I will say it is just great to be back talking with this group. Are you seeing my first slide there, Sabrina? Maybe you can just give me a green light there.
Yep.
Okay, great. Thank you. It's just, I mean, I love this. I've presented with this group, I think this is my 3rd time maybe now, and it is just a fantastic group. I love the work that you all are doing, and I'm thrilled to be providing this update for you today on medical cannabis use in pregnancy. I anticipate I'll have 35 to 45 minutes of presentation time here, and then I will open up for questions, and I can't wait to hear what's on your mind and what additional information you're looking to have. Here are the disclosures, and in my introduction, Subarna mentioned the working groups that I had worked on over the last decade now, really. And it's just, to me, this space is so incredibly interesting because as we all know, cannabis or marijuana is a drug, it is a food, it is a plant, and it's a medicine. It covers so many facets of our structure in our country, and it really is a fascinating place to work with people from all walks of life, whether that's political, police, and legal, and farming, and agriculture, and doctors, and all the way down the line. It's fascinating. So for today, what I'm going to be really focusing on is a little bit more on the typical marijuana use in pregnancy, some of the data around how marijuana is used, the use of cannabis on the endocannabinoid system and how that might impact fetal development, looking at studies, more recent studies that have evaluated the use of cannabis in pregnancy and the effects of that. And then lastly, hopefully give you some takeaways about counseling strategies that you may use as you encounter women who are pregnant and telling you about their use of cannabis. So I've told this story in a prior presentation, but I always think it's important to recognize that it was never my intent to become an expert in cannabis. However, in practicing at this family medicine clinic here in Denver, Colorado, this clinic is a multidisciplinary clinic. And in fact, I think my next picture shows this where, I work in a precepting room a lot of the time with nurses and doctors, residents, psychologists. We even have some social work and stuff in our clinic. And so there's one specific day of this interaction in the precepting room where a resident had told us about a patient that was breastfeeding and smoking a joint a day. And while that was at the time kind of like, wow, that's kind of a lot, and I wonder if that is a lot, it was also this question of the resident telling the patient that that was completely fine. And in my mind thinking, I'm pretty sure that's wrong. I don't think that it's completely fine, but I don't know if it's right. And I had to do some research. There was very little research available at the time. I did report back what I was able to find on that. And the physician who was working with us in this case had recommended me to give a talk. And all of a sudden, in literally kind of an overnight fashion, I became the expert. But it was a perfect mix for me of two passion areas that I've had in women's health and in patient safety. And so being in this space now, talking about cannabis use and pregnancy is really this beautiful combination of those two passion areas. And I think hopefully through the course of this presentation, you'll see that we have much more data than we did 10, 12 years ago when I was first entering this space. And we have a better understanding of what the risks and potential benefits are for patients, the risks more so in pregnancy, but for other patients, there might be spaces and places for cannabis to be used. Today's focus is on the pregnancy. So I was kind of left in this space of like, do I really want to talk about cannabis? And I felt like, well, opportunity is knocking. And with my pharmacy background, I really think of marijuana or cannabis as a medicine, like any other medicine, where there are potential benefits and potential risks. And so we always want to be thinking about that in this space as well. So I'll start with this patient case, which was actually one of the first patient cases I really dove deep in with the patient, understanding what the cannabis use was and why it was being used. This was a 25-year-old female coming into clinic for her second trimester prenatal visit at 24 weeks. She was just taking the prenatal vitamin once a day, wasn't using alcohol or tobacco, but smoked cannabis 1 to 2 times a day. And initially she was using it for nausea, but now has continued it because she felt like it improved her sleep. And while she's aware of these potential harms, she has some critical analysis of the studies, and she really feels for her, the benefits are outweighing the risks. And so the couple questions that we'll cover here initially are, is this scenario common? And what effect could cannabis use have on the patient and especially the fetus? So we're going to jump in now to really talk about the characteristics of marijuana use in pregnancy. So when we look at data, that's the most probably one of the more prominent data sets in the country, and I know you are very familiar with this data set, this National Survey on Drug Use in the United States. This is a survey that collects socio-demographic characteristics, pregnancy status, and specifically for this conversation, we're looking at the cannabis use, both in past month and then how often or frequently they're using that cannabis. And this really started in 2013. They were asked if cannabis was recommended by a healthcare professional. So was it medical use or was it not? Maybe more recreational use or something non-medical. And so when we just look at how women are using it, this is really looking at the past month cannabis use. And you can see here the data back from 2002 to 2003 and now as recent as 2017, where in every part of the pregnancy, even non-pregnant, but there is a higher and greater prevalence of the cannabis use in this more recent time frame of 2016 and 2017. And in fact, they're all, for the most part, statistically significant, except for later in the pregnancy. Now, so what we see here is, pregnant women may not be as high as non-pregnant women, but it's still about 7% of women who are pregnant and using cannabis. You can see that use is most highly prevalent in the first trimester. A lot of times once women find out they're pregnant, they may stop using cannabis. And so that's why we see that decrease in the second and third trimester. This range then goes and went from 3.4 to 7% in this time frame for pregnant women. When we look at past month daily or near daily cannabis use, the prevalence goes down a little bit, but again, we see very similar trends where if someone has been or is a chronic user of cannabis, it increases dramatically in this time frame from 2002 to 2016, but it also now remains significantly increased throughout the pregnancy, first, second, and third trimester. And so here, if the rates have gone from 0.9% to 3.4% in pregnant women who are using daily or near daily cannabis. And so this is a pretty significant increasing trend that we have seen. When we look at whether or not it was used for medical purposes or non-medical purposes, I'll draw your attention to this particular part of the chart, which really indicates to us that there are indeed some women kind of using it for medical purposes or maybe for medical purposes only, but a majority of the women are using it for non-medical purposes. So of the roughly 5% in this weighted average of use, of prevalence of use, 4% of those women are using it for non-medical purposes, which puts them more in that recreational bucket. And that, again, is also potentially risky. And there may be reasons to explore as to why they might be using it. When we look at the rates of prenatal cannabis use among pregnant women before and during the COVID-19 pandemic, I thought you might be interested in finding this information. You can see that there actually was an increase in cannabis use during pregnancy. And in fact, prenatal cannabis use increased 25% during the pandemic. You can see the range there of 12 to 40%, but it's startling to me how much that increased. There's a lot of reasons to explain that: mental health, potentially, maybe people spending more time at home. I mean, there's so many reasons to potentially explain it. This article does go into a little bit more detail about that, but really was primarily reporting just the prevalence of use during this time frame. The last thing I want to point out is the prevalence of marijuana use in women who are pregnant and may already be vulnerable because of other disorders. And in this case, they looked at opioid use or alcohol use. And what they found with this study was that almost, or more than 40% of pregnant women who were using treatment for opioid use with or without alcohol consumption were using marijuana early in pregnancy. And so what this tells us is that there is a potential even higher risk population above and beyond the pregnant population that we really want to be monitoring carefully for. So that just gives you a quick snapshot of some of the characteristics of use and maybe some of the more recent data around the risks or other characteristics of what women might be more likely to use cannabis in pregnancy. So next, I want to discuss the effect of cannabis then on the endocannabinoid system and the fetal development. And especially if we're looking at numbers anywhere from 7% to 40% of pregnant women who may be using. Now, I want to start by saying that there are two types of cannabinoids, and some of you may be very familiar with the cannabinoid system and some may not. So I'll keep this brief, but want to make sure we get everybody to the same place. It's important to recognize that our body makes its own cannabinoids, and that is referred to as the endogenous cannabinoid system. And it literally is in our body from head to toe and acts much like the central nervous system. And in fact, it works very closely with the central nervous system to keep things in balance in the body. Now, we also have plant-based cannabinoids. We have synthetic cannabinoids as well, but I'm not going to keep those aside. These plant-based cannabinoids are considered exogenous cannabinoids, or cannabinoids that are coming from outside the body. And so when we refer to cannabinoids, I think it becomes important as we understand how cannabis works in the body, that we recognize that there is an entire endocannabinoid system, and there is also cannabinoid availability outside the body through plants or medicines. So with this endogenous endocannabinoid system, I mentioned, it has endocannabinoids and the receptors for those endocannabinoids throughout the entire body. In each tissue, the cannabinoid system performs different tasks, but the goal is always homeostasis. And so the endocannabinoid system ends up really, really important for resting, digesting, metabolic processes, processing, our brain chemicals and things like that. The goal is always homeostasis, but it's just like the central nervous system is really working to keep things in balance. And it does this by having interaction with receptors and the endocannabinoids. So the receptors that we know the most about are the CB1 receptors, which are primarily in the nervous system, and the CB2 receptors, which are in the immune system and its associated structures. Now, keep in mind, there are lots of receptors that cannabinoids can bind to. I focus on CB1 and CB2 because those are the ones that we know the most about, and they affect probably what we're going to talk about today the most that we know of. But I just want you to be aware that it's not quite so simple as what I'm presenting here. I just want you to get an understanding of what's there. The endocannabinoids that our bodies make, again, we have hundreds of different types of endocannabinoids. The two that are most common are anandamide and 2-AG. And I always talk about anandamide because anandamide is known as the bliss molecule. And many people attribute endorphin rushes to that blissful feeling, when actually it's probably anandamide that's being made by the body to create that bliss. And so anandamide and 2-AG work to stimulate CB1 and CB2 for that body to work out its processes and stay in balance. Now, the reason this is important is just to recognize, as I've said, it goes, the CB1 and CB2 receptors are prominent everywhere from the brain all the way through the body. And I'm showing you here how these receptors, not only where they interact, but the types of things that the endocannabinoid system is really trying to keep regulated. So things like stress or inflammation, memory, mood, energy balance, immune function, appetite, and many, many, many more metabolic and physiologic processes. The difference here becomes key because anandamide is our brain's chemical, and THC, of course, is one of the active cannabinoids in the plant. And I just would ask you to reflect on the design of this molecule. And what do you notice about this molecule? The molecule looks very, very similar. And so a body's receptors can easily accept the anandamide chemical or the brain's chemical, and it can easily accept THC. Now, the primary difference is that THC is hundreds to thousands times more potent. And so rather than just having the anandamide, blissful molecule, you have a THC molecule that makes you very high, and especially depending upon the dose, right? So there's a psychoactive response that is far beyond the anandamide or the blissful molecule. And so because of this difference in potency, we end up having THC as a psychoactive molecule, much more so than anandamide is. And when we look at the plant, it's not just THC. There are other cannabinoids. While cannabidiol, I would say, is psychoactive because it works in the brain, CBD is not psychotoxic. We do not experience a high from CBD. CBN is another common cannabinoid, and I'm just letting you know there's hundreds of cannabinoids from the plant. It's just that we talk most about THC or CBD. Now, the plant also has other components. It has terpenes or terpenoids. That's where the smell of the plant comes from. There's flavonoids, sterols, thiols, phenols, lipids or waxes. And I just want to take a second to just recognize that this plant is extremely lipophilic. And why is that important? Well, it's important, as I've already mentioned, because it can go straight to the brain. But that lipophilicity is also critically important because it means it easily passes through the placenta. It easily passes through into the breast milk. And so these other critical places of growth and development for a fetus or an infant become impacted when cannabis is used because it can easily pass into those spaces to impact that person's endocannabinoid system. And so that lipophilicity is a key characteristic of the plant that I think is important to recognize, especially for pregnancy. And of course, the cannabis plant can be a fibrous material that's used for, as hemp, for example, in clothes or bags or other material goods. So this plant is, well, I do really want to just say it's just a weed. It is actually a pretty dynamic plant. And of course, most of the information that we have so far is in regards to THC, which I'll focus the most on. I have a little bit around CBD as well, but just to recognize that most of the data we have so far in pregnancy has to do with THC. So I'm going to talk a little bit about endocannabinoid system development. And I think one of the most important places to start is to recognize that the development of this system starts happening at 6 to 36 weeks. And that's very early in pregnancy. A woman may or may not even recognize that she is pregnant yet at that time. And the endocannabinoid system is already going into development. And essentially, what happens is, because that THC is so potent, I think of it as it could be a potential sledgehammer to the system, depending upon how it's being used, how much is being used, the potency of what is being used, and ultimately all the susceptibilities of that fetus as it's growing. And so this very vulnerable time is critical when we think about how an endocannabinoid system develops. So let me give you just a little bit more detail on that. So in pregnancy in particular, we recognize that there is actually a higher level of CB1 receptors in the fetal brain compared with the adult brain. And what does that mean? That means that, with cannabis as an example, being as potent as it is, there's going to be more ability for that plant to be available to these receptors. And we know that these receptors have a very specific role for several developmental events. And I've listed a few of them here: metabolic support, cell proliferation and migration, neuroprotection for the central nervous system, axonal elongation, synaptogenesis, and neurotransmitter, which makes the brain development extremely important and can be impacted as this endocannabinoid system is developing. And what we have found is that when cannabis is used during pregnancy, there's actually a potential for this supraphysiologic stimulation of the endogenous cannabinoid system. It can disrupt endocannabinoid signaling. It can interfere with synaptogenesis, or the formation of synapses in the CNS. It can interfere with development of neuronal interconnections so that the axon development and growth could be impaired. It can disturb the placental endocrine function. And again, that has to do with augmenting some transcription and including the production of estradiol. That's actually a more recent finding. We also know that cannabis exposure can disrupt the neurotransmitter systems. Specifically, it disrupts tyrosine hydroxylase activity, which is a rate-limiting enzyme for dopamine synthesis. And dopamine, as you may know, is very important in our reward pathways. And so by disrupting this tyrosine hydroxylase, you also then are disrupting the synthesis of dopamine, which may interfere with reward pathways later on in life. And what we find, particularly, I'll give you a little cat out of the bag now, is that we don't have a lot of physical malformations that occur with cannabis use. However, what we see is that for some of these processes that would typically reveal themselves later in life, like adolescence, that's where the impact comes in. And so this becomes a very important point when we discuss cannabis use in pregnancy. With regards to CBD, we don't have a lot of comprehensive research regarding CBD. A recent study did evaluate CBD and thought the results showed that it may affect the cognition of the offspring as well as the mood. Their high doses have caused problems with reproductive systems. The potential for CBD products to be contaminated with substances could pose a risk. And I have a whole section of a talk. I talk about product, like kind of buyer beware, and product potential misrepresentation on labels, and actually what's in products compared to what they say is in products and things like that. So there's metal contamination, heavy metal contamination possibilities. CBD products could have THC in it. And so there's a regulatory issue that needs to be considered there as well. And then, we do have CBD available as a medication. Cannabidiol or Epidiolex is the CBD medication. It's used for rare forms of seizures, but we know with that medicine, there's liver toxicity, extreme sleepiness, and drug interactions. And so CBD, although it is touted to be less risky overall, still may have some risk especially in this vulnerable population in pregnancy. And so overall, what would I tell this woman in our patient case? I would say, well, we know that cannabis contains over 100 cannabinoids, and in total, nearly 500 chemicals, including THC. We know that THC can pass through the placenta during pregnancy, and we know that the cannabis has the potential to impact the development of the endocannabinoid system, and that effect may not be seen until adolescence. And so that kind of summarizes for me the key takeaways from this portion of the presentation. So how did I get to those? How do we get to those places? That's a little bit more of the physiologic mechanisms behind it. But now let me tell you a little bit about what the studies show. So most of the studies I'll be showing you in this presentation are all from either this year or last year. And now we have accumulated enough evidence where we can perform meta-analyses or systematic reviews of numerous studies. And so I'm really, I guess, in some ways narrowing the amount of data, because you could take each study one by one. We don't have time for that today, but I feel like meta-analyses really help us understand trends in the data and what's happening. So this particular study published earlier this year was a meta-analysis of 16 studies, including almost 60,000 patients. Now, what you're looking at here is a table about low birth weight, and I'm just going to orient you to the table because I'm going to show you a series of tables as we go through the presentation here. So on the left here, we have the variety of studies that were looked at, the source of those studies. And so, of course, there's references there. And then, of course, they compare in these studies marijuana users to non-users. And then the total is kind of along the bottom. Now, what this tells us is what is the relative risk of a baby being born with low birth weight who was exposed to cannabis. And what we see here are numbers that exceed, most of them anyway, exceed 1.0. And so as we go to the graph on the right, we're looking for either above or below this relative risk of 1, which basically tells us there was no difference in risk. Anything to the left would say, there's higher risk actually in non-users, and on the right would be higher risk in marijuana users. And you're really looking for not just the dot, but also the confidence interval line that's represented there. And in this particular case, all of the studies, except for the one, fall to the right of that line. And then in what you see here, the big diamond at the bottom, helps us to indicate what's the overall data telling us. And in this case, the overall data are telling us that women who use cannabis during pregnancy, the babies were twice as likely, 2.06 times more likely to be born of low birth weight. And so this is a higher risk outcome that could happen with marijuana being used in pregnancy. Next, we see small for gestational age. Now, if you just go to the picture, you can see that 2 studies didn't necessarily, they trended towards higher risk, but the rest of the studies showed higher risk. And so overall, this was 1.6 times more likely for these babies to be born small for gestational age. This is showing us data around preterm delivery, and we could argue that this is, a lot more mixed. However, it was still statistically significantly different when all of them were put together, where, again, this was 28% more likely to have preterm delivery if women were using marijuana. When we look at Nicu admissions, similar data kind of trending to the right or fully to the right, and in total, 38% more likely to have a NICU admission if they were using marijuana, if the mothers were using marijuana. And so this kind of summarizes this data in terms of what were those relative risks. I've added a few more in there that were not maybe it's shown visually as well. So this is certainly a study that you could refer to if you're looking for other outcomes or interested in other outcomes such as APGAR scores or infant head circumference. Some study limitations here, these are all cohort studies. So it's always it's a potential retrospective bias, meaning you're kind of looking back in time, you're looking at records or things that happen. It's self-reporting in many studies. They ask the women, were you using marijuana or not? So you're relying on patient recall. Many studies did not differentiate levels of marijuana use, and no studies differentiated between smoking and other forms of marijuana ingestion. And that is still an area of research that we need to enhance further. What I wanted to do is show you, this was actually something I came across this past year, and it comes out of Canada. And what they did, I thought, was a really nice job summarizing data around prenatal exposure to cannabis and what happens over time with the neurocognitive and behavioral effects. The meta-analysis I showed you is really kind of immediate birth outcomes. But now with this culmination of data that we have, we're seeing some pretty significant issues arise as the children get older, and especially in these adolescent years. So if we go from 18 months to 22 years, you can see kind of across the board, there are deficits in some of the cognitive and executive functioning. At 3 to 6 years, there are some studies that show increased hyperactivity or impulsivity. From 9 to 11, we see not only the cognitive and executive functioning, but we also start seeing things like depressive and anxiety symptoms, psychotic-like experiences or thought disturbances, or even sleep problems. For 14 to 16, again, continued cognitive deficits that we wouldn't want to see, as well as that continuing into the 17 to 22-year-olds. And so I think it's just important to recognize that this isn't just an immediate pregnancy outcome. This is something that, because of that impact on the endocannabinoid system very early in its development, we have potential for long-term consequences. One of the most interesting studies that has been started and is still ongoing is called the ABCD study. And this is data that's been collected in children born from 2005 to 2009, and they have a cohort, a smaller cohort, but a cohort of children that were born to women who had knowledge of their pregnancy, as well as those that had exposure prior to that knowledge, as well as those that had exposure after the mother knew that she was pregnant. And so this study has continued to produce more and more data as they've looked at the children now. In the study that I'll show you right here, the results, all of these children are 9 to 11 years old with the outcomes that you'll see here. But they're looking at a lot of different tests, like you see here, some psychopathology, sleep, cognition, birth weight, premature birth, and brain structure. So this is an ongoing, interesting study. And some of the results of this study are showing us that not only, any exposure in this first graph on the left for a psychotic-like experience, any exposure was statistically significantly higher than an unexposed child. But if the mother continued post knowledge of her pregnancy, that level increased. Same thing with things like internalizing problem. And you just see this trend continue for almost all of these outcomes, where exposed have a higher risk than unexposed. And those that knew and continue to use have a higher risk than those that didn't know and then stopped. Also, same kind of trend for externalizing problems. Same for attention problems. Thought problems, you continue to see this increase of risk. The social problems, also increased risk. Cognition, declining. Birth weight, declining. And so with this, the authors then have said that prenatal exposure after knowledge is associated with a small elevation in risk for psychopathology during childhood. And the child psychosis liability is modestly higher among those that were exposed after maternal knowledge of pregnancy. Children prenatally exposed to cannabis after that knowledge of pregnancy had elevated externalizing, attention, and social problems. And overall, these are risks that may place offspring at increased risk for psychopathology in middle childhood. Again, just recalling that these are 9 to 11-year-olds this time, and they'll continue to monitor them. So I'm really looking forward to getting more and more data from this study. And I wanted to share this with you because this was a newer study, where I think the last time I presented, I was only able to present one of those findings. Some limitations of this study, because there always are limitations. There's bias reporting and misclassification. You're looking at parents or caregiver reports, so there's always a potential for recall bias. There's a reduced power due to a proportionally small number of participants that were exposed to cannabis. The THC concentrations, of course, differ between fetuses with that cannabis and also with cannabis frequency. And so there's really kind of other things that could have gone into these potential confounders as well. They do try to adjust for those confounders, but there may be things that were not measured that could also explain some of these differences. Some added limitations that I'll just say, and I've already hinted at a few of these, for me, especially as a pharmacist, I think about the way that cannabis potency has changed over time. This is showing you data from 1996 all the way through 2019. In the red, you're seeing the concentration of THC, and in the blue, you're seeing the concentration of CBD. And you can see that, this is average, right? And this is marijuana seized by the DEA. So, presumably marijuana that is out there, anywhere from about 4% now up to 15%. And so we see almost a fourfold increase. And I will say in Colorado, the average THC content is actually higher than that. Our average THC content is anywhere now between 18 and 22%. And so that THC potency has not been measured or compared that well, but we know that it's increased quite a bit since many of these studies have been conducted. The other thing, as I alluded to before, is this cannabis formulations. I'm giving you a mini tour of a dispensary here, but there can be differences between the bud here on the left or the top and wax. So for example, wax is referred to as a lot of different things. It could be hash, it could be butter. I'm drawing a blank right now. I'm not gonna spend time there. These are very high potency THC materials that are typically put at the end of a glass pipe and inhaled, but these can be upwards of 90% THC. Now, I don't know a lot of pregnant women, quite honestly, in my experience, that have used hash or wax, but it's a very common recreational used substance because it is so potent. Of course, we have tinctures, which is on the kind of the lower right. We have edibles, which is about the 6 o'clock position there, and I'm showing you there the common joint with the bud as well. So when we're talking about these average THC content on the left, it's primarily what's found in the flower or the bud, not necessarily what's found in things like the hash oil or the wax. So what would I say kind of in summary here? Well, the evidence doesn't really support physical abnormalities. However, prenatal cannabis exposure could place offspring at risk for psychopathology throughout childhood and put some potential birth outcomes. Currently, women should be discouraged from using cannabis, even if they are contemplating getting pregnant, and they should refrain from cannabis use during pregnancy to benefit their offspring. So lastly, what can I do to give you some potential counseling strategies? I think this is often the most difficult part of the job because women are, in the case that we presented, she feels like she's doing what's best for her and keeping herself healthy. She sees these benefits, but yet, we know that there could be some potential risks. So how do we have that conversation? This is going to be much more about kind of resources. So the question here becomes, what counseling should occur? So I will just start by saying, I'm sure many of you are familiar with this document. You may already be familiar with the SBIRT as a technique, the screening, brief intervention, and referral to treatment. There is a document that has been published specifically on preventing the use of marijuana with a focus on women and pregnancy. And so many of you are, I'm sure, familiar with this model, but we know that when SBIRT model is used, there are good outcomes that come from that. And ideally in this scenario, we would be able to decrease Nicu admissions. We would decrease the long-term potential risk that presents itself. Another resource that we have here, it's available readily to anyone, anywhere. I have used it over the years quite a bit. It's through our Colorado Department of Public Health and Environment. The one that you're seeing on the left is really designed for patients. And the one on the right is really geared towards healthcare providers. And I would say both of these resources are very good. They go through a little bit of what I call the myth busters, in how do we answer tough questions, how might you ask your screening questions, which of course is covered in SBIRT as well, but it has a little bit of in-depth kind of practical how to in that resource. And then just some kind of words from a few of our national organizations. I mean, the CDC has really emphasized that marijuana can pass through the breast milk. This is taking more from the breastfeeding side, but it also, as we know, can pass through the placenta. And we really want to be asking women to avoid using marijuana products, and even those containing CBD. For the nurse practitioner audience, they also have a statement that they should ask women about marijuana as part of their routine screening. If women are reporting marijuana use, they should be counseled about those harms and advised to discontinue. It should not be recommended as a treatment, like in this particular case example, not for nausea and not necessarily for sleep. And really trying to, I really try to hope that we can enter into a shared decision-making model about how this can be done effectively. It may not be that they want to stop or can stop cold turkey. So how can we provide an approach that is non-judgmental, supportive, and patient-centered? Other position statements come from ACOG, where there's very similar messaging about encouraging the discontinuation of marijuana use. We should be looking for other alternative therapies, for which there are better data and hopefully better safety data as well. The National Association of Neonatal Nurses also has women asking for women to abstain while breastfeeding as well. And so how do I frame this? My take-home message is that during pregnancy, there are no known benefits. And I will tell you, I give many different types of cannabis presentations. The presentation that I give for audiences related to pain or cancer or seizures is a very different messaging than those that are pregnant or breastfeeding or even elderly or adolescents, because that risk benefit profile is so very different. So with this particular audience, I will say there are no known benefits of marijuana use in pregnancy, and there are possible risks. Now, I've had women tell me, I used marijuana my whole pregnancy and I have an honor student. And I'm thrilled to hear that, but we know that there are potential risks, and that may not happen every time. We need to be advising patients not to use marijuana during pregnancy, ideally ahead of a pregnancy occurring. One of the lines that I will say, because it really has resonated with the alcohol use, is that there is no known safe amount of marijuana in pregnancy. And so we want to try to support them as best we can from abstaining or decreasing their marijuana use and offering evidence-based alternatives to cannabis whenever possible. So in conclusion, we'll open up for questions here in just a minute. We've learned, I hope, quite a bit. We recognize that cannabis may have super physiologic effects on the endocannabinoid system, and that can create potential changes in important aspects of fetal growth and development. There's insufficient evidence to link cannabis use with a specific congenital anomaly, but we do see associations that could be concerning, and especially those in adolescence. So therefore, we should be advising women to avoid cannabis use and promote as best we can communication with women who are using or have used and are going into pregnancy or are pregnant. And so with that, I will say thank you, and I can't wait to hear the questions. I'm going to stop my share, come back into the classroom here, and it looks like we have, oh, these are great. We have some questions already. So are there harm reduction approaches that I have seen to be helpful in reducing the impacts of perinatal cannabis use? This is a tough one, and I will say that most of what I have advised over time comes from the tobacco literature. So while I haven't seen quite as rigorous recommendations about how to do this, I've used similar techniques. So what does that entail? It's an approach for me, although it's a provider approach, not necessarily evidence-based because we don't have it. I look at potency and frequency first. So if potency is extremely high, I try to look at measures or ways that we could reduce the potency. And if frequency is high, meaning daily use or almost daily use or near daily use, trying to decrease the frequency. So those are the places that I start. Those are the two places where I'll start, like, do you know the content of the marijuana that you're using? And many of them do, not always, but sometimes. And then how often are you using? And so that's where I start with one of those two options. And whichever one we didn't pick first, we go to the other one next. And the goal, of course, is to do this as quickly as possible. Can chronic, frequent users of marijuana experience withdrawal? Yes, they can. And so that often leads them back to using. So while we're trying to do this in a somewhat expedited fashion, we also want to be monitoring for symptoms of withdrawal. And so it becomes a tricky one, just in all honesty, but that's the way that I've approached it. Hopefully that's helpful. Yeah, what is your advice on public health communication on perinatal cannabis use that does not stigmatize pregnant and parenting people? This is one of the most difficult situations. I think rather than shaming or blaming or criticizing, it is much more of the approach of we have alternatives that may not provide as much risk. I mean, at the end of the day, most mothers don't want to harm their children or their babies, during pregnancy. And I think it's understanding that there are better alternatives that we could explore. And sometimes, most of the time, in my experience, they've come in from a place of using prior to the pregnancy. They're not typically starting marijuana when they're pregnant, although it does happen, especially with nausea. But even for nausea, we have many other options, even truly natural, not plant natural, but truly natural substances that women could use, like ginger as an example, or some vitamin B. And, there are some things that we can work with to help them alleviate that. And then the trick being that the education around things like nausea only lasts typically for the first trimester, not always, but it's time limited most of the time. And so it's not staying stuck in the space of the finger wagging and you shouldn't be doing this and you should be doing that. It's much more around coming alongside them to say, we have alternatives that may be better and actually work more effectively and more predictably than what you're using now. And some of it is also getting into the reasons why. I've had several cases over the years that women perceive marijuana to be helpful for their mood and being able to handle a pregnancy and or postpartum. The two that I'm thinking of right now were both postpartum examples. And again, we have better alternatives than marijuana to help them through that time. SSRIs and other medications can be helpful. Counseling, other referrals can be really helpful. So hopefully that gives you some ideas. I hope I kind of went in several different directions with opportunities for that, and hopefully that helps you with that. Yeah, so this is a great question as well. How would your counseling recommendations change, if at all, in states with different cannabis legalization policy? It may be easier to have an open conversation in Colorado as opposed to Kansas, for example. I will say, being in this space now for so long, that my experience would tell me that's absolutely true. When legalization happened, well, although Colorado legalized it a long time ago, I will say when recreational came to the fore, it wasn't official till 2014, but momentum really started in 2012. There was a major shift in patients being willing to admit to their use and talk to the doctors about their use of marijuana. And I do feel like the way that I approached it prior to that really being such a more open conversation was, I did it much like I said earlier, in the intake. It's not do you or don't you use alcohol, tobacco, marijuana. The question just simply starts with how much. And if the answer is none, then the answer is great. But the answer, how much alcohol do you consume per week? How much tobacco do you use per week or per day? And how much marijuana do you consume per week or per day? And then it's a question that isn't a yes or a no, that's quite so easily, positioned. It's a little bit more open-ended that way. Is it perfect? No, because at the end of the day, they may still say none. But I think by framing that initial intake and just putting it as part of the routine screening also helps to destigmatize it in a way. I still think it's critical that we ask about it in every state. I think we'd be fooling ourselves to think that's not happening in other states. I will say that the prevalence data are higher in states with legalization, but I wonder often how much that is that the women are willing to admit it and talk about it. So I don't have this disillusion that it's all that different. I actually think maybe it is more accessible in those states, but I really feel like it still occurs in states that don't have the legalization. Yeah, hopefully that's, see if I make sure. Yeah, I think that's been my best approach prior to and now even since legalization occurred. Do we have any other questions that you can see?
Thank you so much for this fabulous presentation. And we do still have time for some questions, and thank you for those excellent questions already. So if you would like to add a question, you can add it to the Q&A or the chat. And while we wait for some other questions, we definitely have some as well that we would love to ask.
Great.
Let's see. So the first one being, what are the differences in birth outcomes for mothers who use cannabis prior to becoming pregnant versus mothers who use cannabis during pregnancy? And I think that this question is also so intriguing, particularly because when you talk about the lipophilicity of cannabis.
Yeah, it's a great question. And I think really what this comes down to, well, I have kind of a two-part answer. One is in many of our survey questions and the data, we classify as you saw earlier, a non-user or a user with different frequencies. So that's kind of how that's separated. So if someone quit 2 weeks ago, they may call themselves a non-user, which is true. It's not true. The caveat, and you mentioned this with the lipophilicity, is that the half-life of marijuana is quite long, of THC in particular. The half-life is approximately 27 hours. And we know even for a one-time user, it could take several days for the marijuana to fully clear itself from the system. For a chronic user of marijuana, especially a very frequent user of marijuana, that could be up to 3 to 4 weeks. I mean, I've had people call me asking about drug testing as an example. And if someone's been a chronic frequent user of cannabis, I will ask them to make sure that they're 4 weeks without using before doing that test. And so while someone may classify as a non-user, when you ask about birth outcomes for women, is there still a potential vulnerable period there? Yes, if they just quit within the last 30 days. However, if they quit prior to that, let's call it 6 months ago, a year ago, it was college days and now I'm 30, to the best of our knowledge, that risk has diminished. There wouldn't be a likelihood of exposure to the fetus for that. So hopefully that helps answer your question.
Great, thank you.
I'm seeing another question in here. Is there a greater risk for women who use opioids, alcohol, prescriptions prior to pregnancy transitioning to cannabis as a less toxic alternative? There is a lot of speculation about this as kind of both ways, gateway drug, or it's considered more natural. What the data have shown so far is that it is a neutral, as far as best as I know anyway. I'm just trying to think of anything I've read more recently. It's a neutral. There is not necessarily more. Now, what happens is women will often perceive marijuana to be a more natural substance. It doesn't mean that they've come from alcohol or opioids or something like that. But a lot of times women will perceive it as a natural substance. And so they perceive it to be safer. And so it doesn't necessarily mean that they'll transition, but they could because of that perception. I'm trying to think about the alcohol data in more detail. I want to go back to that slide, but I think my perception is if they are already using opioid and alcohol, they are more likely to use marijuana. I showed that in an earlier slide. But in terms of like if you were to come in and say, am I going to choose an opioid, alcohol, or marijuana? And you're pregnant, I don't have data to say this is what they would lean towards, except for my experience would tell me that marijuana is perceived as a more natural substance. So hopefully that helps address that question.
Thank you. And I was wondering, we just have a couple minutes left. I was wondering if you could talk about the effects of contact high in pregnancy and if you know anything about that.
So this is a really interesting question. It is being investigated. We call this passive or secondhand inhalation. It's primarily done through smoking. The data that we look at really have to do more with what we call hot boxing, or where people are in very small spaces, like a car or a closet. We don't have good outcome data on that yet. Certainly that could be an interest. I mean, it is being investigated. We're looking at that, but we do not have data and outcomes on that yet. If you are talking about, like in Colorado here, I live close to Red Rocks, which is a famous amphitheater, and many concerts, it's an outdoor amphitheater, and many concerts are known to have marijuana at it. That type of environment is much less risky than the car or the closet or these very closed environments overall. And then especially with pregnancy, it's going to take us a little while to get that data, but I would say in most outdoor environments, it would not be considered a big risk.
Thank you so much for your presentation and for all of the questions and all of the answers. Just a few housekeeping things to end this presentation, and I added this to our chat, is that our Cannabis in Practice webinar series concludes this week. The next and final webinar is entitled A Community Provisioning Center's Insight, Aiding Veterans with Medical Cannabis and CBD. And that's by Tisha Montague on Friday, August 12th. I've included the link to register, as well as the link to our main medical marijuana page, which we will include the PowerPoint slides and the recording from this fabulous presentation and all of our fabulous webinars as well. And we would love it if you could complete our survey. So I've added those links into the chat. And with that, I hope that you all can join me in thanking Dr. Laura Borgelt for her time and her energy and for her knowledge. Thank you so much.
Thank you so very much. I really appreciate it.
Yes. Great. Well, thank you. And with that, we will conclude this presentation. Have a great day, everybody. Thank you.